All right, good evening. My name is Dr. Andrew Palmisano. I'm a board-certified orthopedic surgeon from Jackson County. I support this bill for a couple different reasons I'll get into. First off, the operating room is very much a team effort, as we've discussed already tonight. We each have our role to do in our specific area of expertise. I complete complex joint reconstructive surgeries, and the CRNA in the room performs the anesthetic, and that allows me to do what I do. Just as the CRNA is not qualified to supervise the surgery that I complete, I don't feel I'm qualified to supervise or to perform their role. By having the operating surgeon sign off or supervise the CRNA, liability that is not warranted or appropriate is now shifted onto that surgeon, podiatrist, or dentist. The operating surgeon has enough liability for the procedure itself, and I don't want to take on the liability of the anesthetic or the CRNA. So I think shifting this liability to the appropriate provider makes logical sense. Along with this, I feel many surgeons would agree, and they do not want to take on the liability and practice in the areas where there is excess liability, as we've been discussing. I believe the burden serves to limit care and surgical services and specialties in these areas of the state, which are predominantly CRNA only, and removing this barrier will allow better access and better care for our patients. Lastly, I've spoken to many of my surgical colleagues as well as the anesthesia physicians that I work with on a daily basis, none of which have opposed this bill, and all of which agree that removing the burden from the surgeon, placing the liability on the person that's actually performing these duties would only serve our communities and our patients better moving forward. Open to any questions.
Questions? I have one real quick. So if you're doing that, we've had a lot of discussions earlier on about liability. You're just saying basically it shifts the liability to CRNA, and necessarily if we shift liability, their malpractice has to go up, correct? If you're shifting liability from yourself because of that liability, then it's going to be on the CRNA. So somebody's going to have that responsibility, either the hospital or the CRNA. Correct? I mean, I've got lawyers here, so
honestly, I don't know.
I mean, that's my question. The liability doesn't go away, so by shifting it, their malpractice has to go up if you're shifting responsibility.
So potentially, honestly, I don't know about CRNA's liability insurance.
Okay, but you would feel your responsibility, your liability would go down.
It would go down. I don't think it would lower my malpractice. That'd be nice. But
with insurance, it probably increases both of your liability. Both of your malpractice goes up, I would guess, but I don't know that. But that was a question, so you don't know the answer to that.
I do not know the answer to
that. Okay. Representative Lewis.
Okay.
Go ahead.
Good evening. Thank you for being here. I just wanted to make sure I heard correctly. You said none of your group opposes this. Is that correct? Mm-hmm. And how, how many surgeons are in your group?
So we have about 40 surgeons, and I've spoken to friends of mine, and I was at a previous practice that I've spoke with a couple of those as well, and it's all basically the same concern that we have is liability, and a lot of us we practice outside of Kansas City, mm-hmm. And we don't want to. I don't want to go to some of these communities just because of that, because of the liability issues and things, and it was discussed that some of the particular surgeries, more complex surgeries aren't performed in some of the outlying areas. We're really talking, bread and butter cases and surgeries and things like that don't need to go to a big community or a big, urban area, but that allows more access to care. So even the anesthesiologists that we have at our hospital, they agreed with with that they thought that would allow, better access to care. There's already CRNA only areas of the state, quite a bit of them, and that allows some of those, more standard type cases to stay in those places. A lot of my patients, I do a lot of revision surgeries, so I do hip and knee replacements, and a lot of broken ones or failed ones. They come in from 2-3 hours away. A lot of these patients are 80 years old. They got to drive, quite a bit. They get hotel rooms. They have, family come with them. So some of these things, if they can stay near their community, it's a lot safer for them. But clearly, if they're more complex things or more complex patients in general, they're going to still go to the big city. But it's to allow better access to care for the majority of people in those areas.
Well, thank you. I appreciate that. And I just want to quickly point out, I want to thank all the people in Scrubs who aren't going to be testifying, but are hanging in here, showing their either support or opposition. It's really, really nice to have you all involved. So just wanted to give a shout out to all of you just being part of the process.
Representative Fogel,
Thank you, to inquire.
go ahead.
We've covered this already somewhat, but I just want a specific answer or more technical answer. When you're either pre-op, in surgery, or post-op, are you in the moment directing the dosage and the meds that the CRNA is pushing?
So I am not. To tell you a little bit, of my anesthesia training, when I was in residency, we had to do a month of anesthesia. We had to do an oral exam at the end of that to test out of it. I asked on my first day if I could take that oral exam, and I did, and I passed it. I took a month off. So I did not have any specific training on that. That's not part of orthopedic residency. It was really just to have anesthesia, to have bodies at the place I was at. But I don't know the dosing for, I know the medications of propofol and fentanyl and things, but I have no idea about the dosing or how you would, keep a patient at a certain level or what MAC or any of those types of things. With that said, doesn't mean I'm not involved in the care. If I'm completing a surgery and they start, spraying blood, I, try to say, okay, what's going on? How's your blood pressure? That type of thing. Or if I notice that, hey, I don't hear that beep very frequently anymore. Why are they at 40, heart rate? Well, then, yeah, you're involved in that. But I'm not telling them what medications to push, and I have no idea what to tell them.
Okay, so
Just
when you
like
walk
they can't
into
tell me
the-
what to do when I'm,
Right.
operating.
When you walk into the surgery room, that's already taken place, and now you're presenting the patients in front of you. At what point are you consenting or signing off in that collaborative practice the dosage and the meds that were pushed? When you sign the chart,
So
or
it'd be after the procedure, but and they have their protocols and things, but yeah, I can't give them any specifics of, they couldn't ask me. They could ask me, and I'd just look at them like I'm not sure how to help you with that.
okay,
So I'm in the room, yes, and I'm still part of the care team, but that's what they've went to school, went to training for. In the majority of cases, if not all cases I'm in, there are anesthesia physicians at my facility, but they never are in the room. They're not the ones performing the day in and day out, in the trenches kind of the procedures. And to be honest with you, a lot of them, we'll do spinal anesthetics for some of our replacements. And if you're not familiar with them, basically you're putting a needle in their back, trying to numb up some of the nerve roots so that we can perform the surgery. If they're not able to get it, then you would call in your anesthesia attending. Well, they come in and oftentimes they go, if they couldn't get it, they do it all day long. I can't get it. And so, each have their roles and they're necessary, but, specifically for liability and talking about access, I think that's what this is about in my mind.
okay, thank you.
Representative Keithley,
Thank you, to inquire.
go ahead.
I just want to clarify some of that. As far as I understand it, I don't think that this would really shift liability at all. I think it just removes you from the liability or removes the physician. I mean, a CRNA carries malpractice as CRNA. At least that's my understanding. I'm a lawyer. If I had a client, and I don't do malpractice, medical malpractice, but if I had a client who had an issue go on in surgery, I would sue the hospital, I would sue the doctor, I would sue the CRNA too. So, I mean, everyone's on the hook for the liability. You're not shifting liability, you're just removing yourself from that liability equation. So, I mean, that's how I understand it. And I want to make sure that I'm clear in understanding if that's how you see it, because I think that's different than shifting it, saying, well, the CRNA is more responsible for whatever's administered. And that might be true, but and I would pose the same question to you about, in terms of, in your experience, your preoperative care with the patient versus, in your experience, the CRNA or the anesthesiologist preoperative care? Because I think that's an important distinction here when we're looking at the patient's involvement and how much they're vetting, how much they're controlling their team, especially if, the hospital or the facility or you are seeking to remove yourself from the liability equation. I start questioning that when you're the one who is putting the team together, the facility is the one who's putting the team together, and the CRNA is not necessarily being chosen by the patient. The patient's choosing you. They're not choosing the anesthesia team to deliver it necessarily. Unless I could be wrong about how that plays out, but that's in the couple surgeries I've had in my life, that's how it's played out.
Yeah, so I agree. For each facility will have their CRNA team or have their anesthesia team, and that's not necessarily the patient choosing that person. For what I do in total joints, we have you either talk with the CRNA or the anesthesiologist beforehand, so you have met them beforehand. Usually it's a week or two before, so that we can develop the plan. I think talking about the liability as well is I still have plenty of liability. I just now, my concern is having liability of the anesthesia itself. So if something goes wrong with anesthesia, obviously, like you had mentioned, you're going to name everybody that you possibly can, plus, their family members, anybody. You put it all on there and see how it shakes out. I think for the anesthesia portion of it, if I'm not the one directing it, I didn't have to sign off on it, that type of thing, then that hopefully would remove me from it and keep the liability on the person that is performing that. Just like if something goes wrong in surgery, in the surgery that I'm doing, the CRNA or the anesthesia physician, they're not on the hook for that. They're not going to be named for that. So shifting may not be the right term, but I think applying liability to where it should be is probably, more of a correct statement.
And then if I could just do one more, because I think it might actually be in the interest of time, because I'll pose this question to you, but I really mean it for, I think, anyone else who comes to testify here, because I can see myself asking this at the same time, because it's the second time I'm asking this. You said that this is about access in your mind, expanding the access, and there's been a lot of conversation here tonight devoted to expanding this to the rural areas. And I'll be honest, I'm struggling to see how this actually is going to, how this as presented is going to actually increase the amount of surgeries we're able to perform in the state of Missouri. Because although we'd be giving CRNAs this independence within each surgery, the CRNAs aren't really the bottleneck here. I think it's the physicians who have to be involved in the surgery one way or the other. So, you're addressing the CRNA independence issue, but you're not addressing the much larger bottleneck that is who's going to be doing the underlying surgery. You still have to have a physician in the room. So if we're talking about this in context of whether a liability shield for you is a good idea, let's talk about that. But if we're talking about this in the context of, this is a good idea for expanding access to rural areas, I don't really see that right now, and I'm trying to figure out how does this actually accomplish that.
I don't think it's access of CRNAs. I think it is access of certain surgical specialties. With that said, I'm a subspecialist, and I do a lot of cases that have a lot of liability associated with it, and doing a lot of revision work. And going to some of these outlying places where I would have to be the supervising physician for the anesthesia, honestly, it's easier to stay in the city and not have to deal with that. So I do agree with you. I think it's a bottleneck, but I think that by releasing some of that, at least in my opinion, and from talking to my colleagues, they would be more likely to go to those areas to perform these surgeries. So it's not an access to CRNAs; it's an access to the care that a lot of us just don't want to. It's more liability that we have to deal with, more issues, more burden. Some of my colleagues have tried to learn a bit more about anesthesia before they go to some of these places. I'm just like, I did 6 years of training after medical school, and none of which was anesthesia. I don't really want to go learn that job too, and I don't think I could appropriately. So I do agree with you, but I think the access to care is getting some of the physicians to go to those areas and remove some of the burden for that.
Questions? Seeing none, thank you for your testimony, and appreciate you spend the night.